Hi, everyone, and welcome. We're going to talk about common and diagnostic characteristics of autism spectrum disorders. So, this is an introduction to ASD, which is also known as autism spectrum disorder. So, the official, definition of ASD is a neurodevelopmental condition that affects communication and social interaction and behavior. It's seen in approximately 1 in 36 children, and so that is from the CDC from 2023. By the time you're watching this, there might be more recent data. Keep up to date on that because it's very important if you're gonna be within this profession to really understand what's going on. In this profession, as a behavior therapist, you're most likely gonna work with kids with ASD, but you also might work with other disorders. It is a spectrum, so there's a wide range of abilities and challenges and presentations of ASD. I always say if you met one person with ASD, you've met one person with ASD. Every single person is gonna look a little bit different and have unique characteristics. It's really important that we don't overgeneralize even what I'm talking about within this presentation. One person may have these characteristics I'm talking about and another person may not. The common characteristics, which we gather these from the diagnostic criteria, is there's typically differences in social communication. Social communication is in general a challenge. There's also challenges with nonverbal communication, so eye contact, gestures, and sometimes there's struggles in developing and maintaining relationships, often related to difficulties in communication. And, a lot of people are more thinking of this less as, we say difficulties when their communication is not what mainstream communication is like for most of us. But just because it's different doesn't mean it's worse or better. It's just different. So they are just communicating differently. And because this world is all developed for how typical people communicate, those things become challenges for them. And you'll hear me say this a lot. Instead of thinking of autism as a disorder or something bad, think about it as a difference that if we modify the environment correctly, they can thrive. You want to continually bring it back to that. How can I modify the environment to help? Repetitive behaviors, so stereotype movement. So the typical ones we always hear is hand flapping and rocking. However, everybody has repetitive behaviors and they might be different than that for a person with autism. So highly focused interest is also often a characteristic. With repetitive behaviors, I want you to kind of think about yourself and think about what repetitive behaviors do I have, so you can sort of understand that everybody has them. Little kids, under 3, but even older, all engage in repetitive behaviors. A lot of times they engage in a lot of repetitive behaviors. A lot of that is learning. We repeat things over and over again to learn it. Just taking a sip of water from a cup, a child might do that over and over and over again because they're really kind of learning how to grip it, all those things. And that doesn't mean that person has autism if you're seeing repetitive behaviors as a child. People get really confused by that. And then sensory sensitivities. Again, we all have sensitivities to our sensory environment. There's people who hate bright lights. I hate bright lights. I like natural light from outside, and bright lights kind of give me a migraine if I'm, in a room with them too long. So that's a sensitivity. But it's the same thing. People with autism often have a lot of sensitivity to auditory, tactile, visual, or vestibular input. So they either really like it or they don't like it, and they prefer environments without it, or sometimes they prefer environments with a lot of it. I worked with one adult for over a year. She just loved the vestibular, and we went to amusement parks a lot. We were lucky to live in a community where there was easy access to amusement parks. And she just loved roller coasters so much that that kind of became an activity we regularly engaged in. So the DSM-5 diagnostic criteria is split into two parts, and they need quite a few things in both of these domains to meet the criteria. One is the social communication and interaction deficits, difficulty with the reciprocal conversation, but sometimes hard to continue a conversation past those first few statements, challenges in nonverbal communication, gestures, eye contact, and struggling to develop and maintain relationships. The second part is restrictive, repetitive patterns of behavior, interests or activities, stereotype movements, and then rigid routines and highly focused interest. And then we have those sensory processing differences. And how this works is we have these domains, and there's a bunch of criteria under each domain, and they need to meet 5 out of the 10 criteria to meet that domain. You're not going to be diagnosing autism as a behavior technician. And so you just need to be aware of this. And if you're interested, you may want to do more continuing ed or take more classes on it. It's great information for you to have, but to be part of a team diagnosing individuals with autism, you would have to do some more education. To do it privately, it's often a clinical psych license or to be a doctor. And then to do it in the schools, that would be the role that does that is a school psychologist, and that is a master's level license. The school criteria is different than this. It's similar, but it's different. All schools for all disabilities have a different criteria than the DSM. So medical doctors and psychologists are most often using the DSM to diagnose, while school psychologists, special ed teachers, they don't diagnose, but they're part of that process. Speech therapists are all using the education code, and they are different. And you should know that. You'll see once you start working with families like, oh, we have eligibility, but not diagnosis, or vice versa. So that you're aware of that and kind of have an understanding. So early signs. So when they're little, what might be signs that they may have autism? Oh, and I'll say this really quickly. I alternate between people first and identity first language because it's actually pretty split. Some people like identity first, some people like people first. When I'm with an individual, I always ask their preference, and that's what I'll use, whatever they prefer. For you, I would always ask people's preferences for that, and I have a whole lesson on that. If you don't know what I'm talking about, you will, don't worry. So early signs, there's a lot of limited or absent eye contact. I'll talk about this later on. That used to be an area that we often intervened with, like increasing eye contact. Recently, a lot of adults with autism have indicated that making eye contact is very uncomfortable for them. If you're with a company intervening on eye contact, I encourage you to either help inform the owner and the BCBAs or the behavior analyst why that is wrong, provide them the research and the information. And if they continue to push eye contact as an intervention or a goal, I would possibly look for another company. Forcing someone to make appropriate eye contact, or what, the normal population makes as far as eye contact goes, is what you're trying to do is make them fit the environment. So if they're not making eye contact and other people are finding that, let's educate those other people about how eye contact is difficult. And then it shouldn't be a problem anymore. The other thing with eye contact is it's a cultural issue. How cultures deal with eye contact is very diverse. Some cultures like a lot of eye contact, and some cultures like almost no eye contact. So this idea that we should make eye contact or train people to make eye contact might not be taking into their culture. It's important to keep that in mind. When I'm working with people, that's their choice. However they want to deal with eye contact, if they like giving people eye contact or if they don't, that's their choice, and I respect that. And then I try to help them learn ways to express that to other people. So if they're without me and they're meeting a new person and they can tell the person's a little uncomfortable, they can say, "Oh, I have trouble making eye contact. I hope that's okay." That's probably the number one concern that parents have with little kids. It's kind of the obvious one. At 1, we should start having some words, and then, like, at 1.5, they should be putting some words together. At 2, we start seeing our first sentences, and parents are really excited about that, the speaking, first baby's first word, all that. So when it doesn't happen on the normal timeline, parents are very aware of that problem. It doesn't necessarily mean they're gonna be autistic or meet the diagnostic criteria. A lot of kids have atypical speech when it's other things. The most common one that I see all the time is, I call it the good parent syndrome or the good sibling syndrome. It's where our first words are usually something we want, like water or milk or cookie. And if somebody provides the child everything they want and need before they have an opportunity to say it, they're never going to say it. Everyone's just giving them what they want. A lot of times this might be an older sibling who's, "Oh, I'm hungry. I'm gonna have crackers." "Oh, here, to my little sister, you can have some crackers too." Or a parent who's just anticipating needs really well. Limited interest in social interaction, so it's disengagement from social situations and preference for solitary play. This can be multiple things, and it's important to know that this is many things. Sometimes it's that social situations are difficult, so I'm not gonna do it because it's difficult, though I do desire it. And sometimes it's, I just don't desire that. I prefer to be by myself. As a little child, it's good to keep that in mind, because pushing socialization on someone who just likes to play by themselves is a little bit wrong or mean. Intense focus on specific objects or topics, so they get preoccupied with particular toys, interests, and routines. It's hard to break away from these. Sometimes this can just be a routine. A child doesn't necessarily, enjoy, or they might be enjoying it, but, like, have interest in the routine, but they're just so used to this routine that they're not able to break away from it. I've seen toileting routines where they just have to do every step of that toileting routine. Now, if that's functional, we're just gonna let them do it, but sometimes that's not functional and they need to do another step or take away a step. And then unusual sensory responses. So because of that sensory sensitivity, if the lights come on, they might run out of the room or cover their eyes. A lot of times, the one you see all the time is when the toilet flushes covering ears. It's just a really loud sound. I've seen typical kids do that. That does not mean somebody has autism if they do that. But it is a loud sound and it's kind of jarring. You don't really, if you're in a public bathroom, you're not the one pressing it, so you're not expecting it all the time. But sometimes our response would be a little bit bigger than expected. So across a lifespan, and this is super important because we always have this idea that it's all kiddos, right? But those kiddos grow up and they still need support. They still sometimes need our help. A lot of people aren't thinking about that. I even think a lot of people getting into this field don't think about that. They're thinking, "Oh, I'm going to play with these cute little kids and help them learn to brush their teeth and learn this and that." And that's great. If that's your passion, go for it. I'm never telling people not to pursue something they really want to pursue. I'll let you know there's a good chance you'll be working with older kids in most settings, as well as younger kids. It's all sometimes a range. When they're little, we're seeing these delayed milestones, and there's a lot of focus on getting that diagnosis and figuring out what's going on. We see a lot of differences in their play, their sensory sensitivity, and then they start having social challenges as they become adults, especially in the kind of world we're currently living in. They often have to mask. Masking is when an autistic individual attempts to present typical to fit in. And that's not being yourself, and it takes an emotional toll and can cause anxiety and depression. They often have social fatigue. It's real hard to be in social environments, and they get fatigued, and they have unique strengths. Just think of yourself, and maybe you do have a diagnosis. I do have a lot of autistic individuals take this course, or another diagnosis too. Could be anything. But say you're socially typical, just think of that. And you go into an environment with new people, and you're good at socializing and you do a good job, but these are brand new people to you. It's like a work setting or something. I'm always tired after that. If it's not those people I'm super comfortable with, that I have a great relationship with, I get fatigued. Now that's with I'm socially fairly typical. So if I'm getting tired, just imagine what it's like if you have that layer of social difficulty on top of it. Late diagnosis, a lot of adults are receiving diagnoses way late in life, and that's difficult because they didn't receive early intervention or support growing up. If you talk to them about what their childhood and teenage years were like, it's often hard. So they're dealing with all that history of struggling and now trying to find ways to support themselves. There's not a lot of support for adults in the first place. It's hard to get any kind of therapy covered. So that makes it all difficult. Sensory processing is often different. We have two types. We have hypersensitivity over responsiveness. So that means heightened sensitivity to sensory stimuli, like loud sounds, bright lights. And then we have hyposensitivity, under responsive, reduced sensitivity to sensory inputs, leading to seeking out sensations. It can be both or either. Everybody has a mixture of these for different sensations. Some people just love roller coasters. That's probably a little bit of hypo. When you look at some of those hyperactive boys in a school, they're always kind of attacking each other or wrestling. That's usually hypo because they want more sensory input. But we all have a range on each of our inputs, and then we're going to seek or avoid things to meet our sensory needs. The common ones are auditory sensitivity to loud sounds, tactile discomfort with certain textures or putting certain things on us, visual preference for dim lighting, and proprioceptive and vestibular, which is the deep skin pressure. Strengths and challenges. A lot of strengths come with autism. One is attention to detail. A lot of times they can catch smaller things that we are, just the typical person isn't catching. And there's a lot of, jobs or activities that is a perfect skill for. So it's really, when you find something that someone's good at, when you're working with people and you figure out something, it's really kind of exciting and very rewarding for you and for them. Specialized knowledge. So a lot of times they'll gather really specialized knowledge about this area of interest, which also can be a unique strength. I had a student who was obsessed with mushrooms. He knew more about mushrooms than someone with a PhD in fungi or mushrooms. So he had that knowledge in early high school. So that's a really unique strength. Problem solving skills, they bring very different problem solving a lot of the time. It's almost sometimes the simpler way that we're not thinking of. That's what I found. They're also very honest and very authentic. There's been a lot of reports that it's very difficult for an autistic individual to not necessarily, I want to say lie, but sort of, pull the wool over someone's eye, those kinds of things, be very manipulative. Now, that's not everybody, again, everything in this, it could be one and then not the next person you meet. But that can be looked at as a strength. A challenge is they get really overwhelmed with sensory input a lot of the times, and so it can lead to anxiety or distress. And then there's often social misunderstandings, so that can be very difficult as well. So myths and misconceptions. All autistic individuals lack empathy. That's not true at all. I've honestly never met one that lacked empathy. They're showing empathy in a different way. A lot of times they can be more empathetic than other typical people, but also they can just be the same. They're just often showing it in a different way. autism is caused by vaccines, so there's no scientific evidence to support that. And then autism is a lifelong condition. So if you get a diagnosis, typically that means that the rest of your life you're going to have some of the characteristics. The diagnostic process. Right now, school psychologists do the work in the schools. To access services in the school, you need that school eligibility. But then for insurance, which most behavior technicians, that's where, you're working within the insurance world, you need a diagnosis. The diagnosis, a pediatrician can do it, but really it should be a pediatrician who's focused on developmental issues. Child psychologist, again, a psychologist can do it, but child psychologist would be better. And neurologists are the primary professions right now, and psychiatrists as well. And the difference between a psychologist and a psychiatrist, a psychiatrist went to medical school, became a doctor, and specialized in mental disorders and psychoactive medication. It's a specialty after normal doctor training. So just in the same way, if you go and see a neurologist who specialized in neurology, they did their regular doctor training and then specialized in neurology. It's the same for psychiatrists, but they specialize in mental health disorders and medication. And psychologists, they get a PhD, which is a 5-year plus degree, often longer. Not everyone with a PhD in psychology can get licensed. So they're a specific degree that can get licensed, and then they got licensed in the state they're working in. Common assessment tools, there's a lot of them out there. ADOS is the most common that's being used. It really should be very comprehensive, so it should look at developmental history, behavioral observations, standardized assessments, all to show that they meet the diagnostic criteria. In the schools, this is almost always done. You're not going to find a lot of short eligibility reports. The federal government, basically, IDA 2004, which is our SPED law, that dictate what has to go into those assessments, and it's quite long. Unfortunately, at the private level, there will be doctors who will just kind of observe the student or the child or the person and say, you have a diagnosis. That's not ethical. It really should be a very comprehensive practice. Neuroaffirming approaches. We don't want to intervene for normalization. We want to push acceptance and try to modify the environment to help the person. So interventions for normalization is interventions to stop, repetitive behaviors, interventions to push eye contact, interventions to make them look more typical. We are, as a field and as a world, moving away from that. When there's severe behavior, we may need to intervene for the person's safety, other safety, and property safety. We will intervene to reduce behaviors for that reason. But all other things, we are not doing behavior reduction on as much. These little things that the environment can live with, that we don't need to reduce that behavior to make the person, it's not going to make the person safer or others safer. It's just like a weird behavior they engage in and enjoy. We're going to leave that alone and try to make the environment accept that behavior. Another big push is providing accommodation, so like changing the environment, and self-advocacy tools. So empowering autistic individuals to understand and communicate their needs so they can advocate for themselves. Looking at them as the expert on themselves because they know what they need the most, especially when you have older autistic individuals or you have individuals who communicate really well. You want to give preference to whatever they're saying. Encourage self-regulation instead of behavior compliance. The word compliance is so overused and doesn't really make a lot of sense if we talk about they're going to be compliant or what, I'll talk about a lot later on, but that's a confusing concept in itself. But we're going to push self-regulation so they can control their own behavior and know when they can engage in this behavior, when they can't, And then a strength-based approach. We're going to highlight talents and try to utilize them to better the environments and help autistic individuals. Summary and key takeaways. Autism is a diverse lifelong neurodevelopmental condition. Early recognition and support can improve quality of life. Sensory sensitivities are a key part of the autism experience. Autistic individuals have unique strengths and challenges, and neuroaffirming approaches foster acceptance and empowerment. Thank you. I'll see you in our next video.